This conference will now be recorded.
Assalamu alaikum warahmatullahi wabarakatuh. Hello everyone, how are you? Welcome in for this session today. It's a quick session, but actually I have found that I have like 1 to 2 spare hours, and I'm happy to answer my colleague request to do the session today just to discuss the problem of cervical screening and its update in 2020. Okay, so some of you are already my course candidates and they have listened to this lecture before, but today I'm just revising some tips and flashcards. And some of you are new today to my sessions, and I would like to welcome all of you. I would like also to especially thank Dr. Mustafa and his group because they are really doing a very good job to helping the candidates of September and next January, inshallah. Okay, so let me start by the update in the cervical screening and how can you approach those questions in the exam. We know that the cervical screening is a very important part in each examination, and maybe because it had been changed and starting by the virus test rather than screening for the cytology test. Okay, and they also have changed the follow-up for the famous lesion. Okay, so I will start by the principles and the explaining the 3 algorithms that came from the guidance itself, okay, and my own approach to it. How you gonna solve this in exam? As I always say, just read the question, the scenario. First is situation awareness, means that you should be aware what is the current situation. This patient here in the GP clinic or in the colposcopy clinic, or the patient is coming for follow-up, the patient has been received treatment or not, okay, and maybe the patient had a diagnosis by the colposcopy, but she would rather have the conservative management and she would deny to do anything. Okay, so how you gonna plan her follow-up? Okay, so what I'm asking you first is the situation awareness. Second, we will apply some basic concepts. Those basic concepts will be the key to the answer. Okay, so I will start by revising the most basic fact from the cervical screening, which is now said it started by the human papillomavirus test, and this is the primary testing. When the human papillomavirus test comes negative, so what shall you do to the patient? And when it comes negative, positive, what shall you do to the patient? And when it comes inadequate, what shall you do to the patient? Okay, so these are the basic facts we will cover today. So if the patient has HPV negative, she will back to routine screening, and the routine screening is still the same, not changed. It will be changed maybe in the near future, but till now it is still the same, which is every 3 years from the age of 25 till the age of 50. Yes, and from the age of 50 till the age of 64, the routine recall will be every 5 years. And my first tip today is please differentiate in the exam, in the answer, between the routine recall answer option and the option of ask the patient to come again for reassessment in 3 years or in 36 months. Even like if the patient was 33 years old, Dr. Rabah, yes, even if the patient was 33 years old, her next routine screening should be after 3 years, but they're different in the option. Why there is different? Because they're different in the algorithm. And what you need to say to the examiner is, sir, I have read the guidance and I know the difference. Okay, so this is how we gonna start our equations of the cervical screening and how to approach it. So I would say, first, HPV negative patient sent to routine recall, either the 3 years or the 5 years. If the patient had inadequate HPV test, what shall you do? You will ask her to repeat the test in 3 months. Okay, so if you find inadequate HPV test, your answer will be repeat test in 3 months. If you have HPV positive, found to be positive, this will result in reflex cytology, means the patient should have a cytology screening after the HPV positive testing. Okay, so let me see what will happen, and hopefully that you can, oh my god, sorry, this is not this slide. Okay, so this arrow, if you can see it here. So we have our patient, Ms. X, with HPV positive, and she had the cytology as a reflex. Okay, so next step is cytology. Okay, let's see. While she had cytology normal, okay, what you will do to her? If she had her cytology normal with the HPV test positive, next thing is to screen in 12 months. This is your next step. This is the answer. So, abnormal cytology with HPV positive, you should refer her to the colposcopy. So, it will depend. HPV positive here, you have either 2 options. Hair cytology is normal, so screen in 12 months. Hair cytology is abnormal, so colposcopy referral. Let's see what happened for this woman after we recalled her to repeat the screening test in 12 months. What happened is, we found her test negative, HPV found negative. So what shall you do? You will ask her for routine recall. Okay, so we will take care here, it's a routine recall. We found otherwise in the other scenario, HPV test came positive. So this case will have a reflex cytology, and according to cytology, either normal or abnormal level results. Okay, so I would say that hair cytology came negative. What we would do, if the cytology came negative, while HPV positive, we will repeat again in 12 months, meaning that I will give her a second chance. Okay, another 12 months. So now I have given this patient 2 chances of the 12 months rescreening. First, when she had her first sample of HPV was positive, I give her in cytology normal, I give her screen in 12 months. Then I repeated after 12 months, HPV test and came positive again. So I will do a cytology, and according to cytology, I will choose my option in the exam. It will be repeat again in 12 months. So remember me here when I'm saying to you, give the patient second chance. Okay? Second option or second scenario. Our patient HPV positive with abnormal cytology. What shall you do? If HPV positive with abnormal cytology, you should refer her to colposcopy. So it's always like this. HPV positive, plus abnormal cytology equal colposcopy. Okay, so let's see in our follow-up with this patient that she had repeat screening in 12 months, the patient who had the second chance. Okay, so here, this is the further follow-up. Patient had the second chance and her HBV negative and her cytology is normal. So I will send her for routine recall. While if the patient had the extra 12 months, means the patient had her second chance, HBV still positive, what shall you do? You will refer her to the colposcopy. And my advice here that will be ringing in your ear in the exam that the patient had her second chance and HBV came positive. So whatever the cytology is, please refer her to colposcopy. So Dr. Rabah, you mean that HBV positive and cytology normal, I will still refer her to colposcopy? Yes. Why yes? Because she had a persistent HBV positive for 2 years. Okay? So this is how the things comes, and this is the original algorithm of the guidance, and we will try to solve it together by our unique way. So come here and see with me, please. HBV testing, this is the primary HBV screening. If the HBV testing came positive, okay, so look to the cytology. Patient should have a reflex cytology. Cytology came negative, so give her rescreen in 12 months. While if the cytology came abnormal, you will do a colposcopy referral. And for here, we finished. Which arm is still open for chances? The arm that's still open for chances is this arm here. Well, the cytology came negative, but her HBV positive, and you advised her to rescreen in 12 months. So I'm here coming after 1 year, seeing the same patient. I offered her rescreening, and according to the screening result, I will see what's happened. If her rescreen came negative, so routine recall. If her rescreening came positive, you will do reflex cytology. Reflex cytology came cytology negative, give her a second chance. So this patient given a second chance. While in the second chance, we will see what is the result. If her HBV infection cleared, means that HBV test negative, send it to routine recall, and now you're happy. You didn't do any unnecessary intervention, and the patient immunity is able to clear the infection. While if you find still persistent HBV positive, cytology negative, or inadequate or abnormal, you still do colposcopy referral. This is what the guidance said. And I'm saying to you, so remember what Dr. Rabah said. She said, whatever the cytology result is, refer to colposcopy. So he will not bother you in the exam. He will not make you confused. He will give you HBV came positive and cytology came negative, and you will look, okay? This patient here, what comes the situation awareness. This patient has been given her second chance. This patient in 2 years follow-up, okay? 2-year persistent HBV positive. So this patient should be referred to colposcopy, okay? Whatever the cytology is. Okay, so I'm trying to be clear and I'm trying to talk slowly because I know that this needs time to digest. Okay, and even if you are in the revision, your final revision, you have to be careful. Okay, because this is the new algorithm and you have a very high chance of this algorithm comes to you in the exam. Okay, so let me see what's next. Okay, my next slide is start to discuss the management of the CIN and CIN1, CIN2, CIN3, and so on. Okay, and this slides keep popping up, okay, because maybe want to be discussed with you today. Okay, so guys, I will start here okay, yes. When he gave you the second algorithm, he started the algorithm by two arms of the colposcopy examination and what happened after a colposcopy examination. He started by the arm of adequate colposcopy examination or inadequate colposcopy examination. Okay, so let me see what is the arm we start to now to discuss it, because we have said situation awareness, and situation awareness every time. Okay, so yeah, this is the official one. And I am a big fan with the guidance and the official algorithm, because this is a side of your exam question. Here comes your exam questions, here comes the scenario, and you have to be able to read it and respond adequately with the guidance on words. So if you have in the exam options that looks like attractive option to you, but not in the guidance on words, please don't choose those options. Okay? We said you rule in the exam to prove to the examiner that, sir, I have read the guideline. Okay, so let's see. Colposcopy examination, here are two arms. Okay, the arm of adequate finding, so he will tell you in the scenario that the examination, colposcopic examination, was adequate, okay, or was clear, or the second possibility that the colposcopy, while the specialist is doing the colposcopy, found some difficulty, okay, or found some cervical stenosis, or is not able to see. So this is called inadequate colposcopic examination. Okay, so if you have a colposcopic examination which is adequate, give you the result of CIN 1, 2, or 3, you will have some particular pathway. While if you have the colposcopic examination inadequate, and this will start from the case, okay, you will have another management. So this looks like complicated. So how can I deal with it? I will just divide it, and I will divide it in my own flashcards, and you will see how this complicated one turned into easy and clear one. Okay, so let me go. Again. So we have colposcopy adequate and abnormality detected. Okay, so we are in the arm of adequate colposcopy, and you have found that there is abnormality. What is the type of this abnormality, and how can you approach this in form of the treatment and follow-up? Let me see. We have some forms of abnormality. It's either CIN1 or CIN2 or CIN3 or CGIN. Okay, so those are the possibilities you will have. I have put the CIN1 in special category while I have gathered CIN2 and CIN3 in one category because they are the same in the follow-up. Okay, CGIN is very important and very risky and need more frequent follow-up. So we will see. CIN1, what's happening in CIN1? If you have discovered by the colposcope that this patient had abnormality while your colposcopic examination was adequate, so patient have CIN1. CIN1 means recall in 12 months. Okay, will you treat a CIN1? No, I will not treat a CIN1. CIN1, I will ask her to come as recall in 12 months. And in the 12 months, what's happening? Okay, what's happening is I will check the HPV. Going to the exam scenarios, you have CIN1, colposcopic examination was adequate. Okay, confirmed by the biopsy, or he may tell you that colposcopic impression of CIN1, then it's okay, both are the same. What shall you do? I will recall in 12 months. Then next, patient comes after the 1 year, the 12 months you have offered, here as a chance. What you will do? Will you repeat colposcopy? Please, no repeat of colposcopy here. Now, the new algorithm and the new guidance focus on the HPV testing. Okay, so HPV, the follow-up by the HPV test. HPV test came negative. What shall you do? Will you send her back to routine recall or recall in 36 months?
36 months.
Yes, thank you very much. Excellent, doctor. So I will recall her in 36 months or recall in 3 years. But doctor, in the exam, the patient's age was 29 and he gave me 2 options. Back to routine recall or recall in 3 years. Which one I would choose? Please choose the one that's specified with recall in 36 months or recall in 3 years, because this is the guidance. Doctor, it is the same. Please follow the guidance, stick to the guidance own words, okay? Your problems usually in the MRCOG that they will give you 1 or 2 attractive answers alongside with the true one. Which one is the true one? The true one that came as a guidance on words, okay? So you have to read the guideline, or at least to know the algorithm, important algorithm in each guideline. So here comes this slide. CIN1 on biopsy or colposcopic impression. So I will recall the patient in 12 months. Patient HPV negative, so I will recall in 36 months. So unfortunately, this was not the case. The case that Miss X comes to me after 1 year and I have found that her HPV came positive. So I will give her another chance. Second chance here? Yes, second chance here. She had CIN1 diagnosis? Yes, she had a CIN1 diagnosis. She has been given 12 months recall? Yes. HPV came positive? Yes. Second chance if her cytology negative? Yes. Okay, so HPV positive, I will look to the cytology. Cytology came negative. I will give her my second chance of the 12 months recall. Okay, so If hair cytology came abnormal with the HPV positive, what will be the action? The action we are
Refer to
sticking to the
colposcopy.
basics, and basic action is refer to colposcopy. So we are good here. So we know what we are doing. Let me see. Here is a little problematic case. Okay, but it's not a real problem. It looks like a problem, but we will solve it now immediately. The patient cytology negative, okay, and HPV positive. So I asked her for routine recall, for recall in 12 months. So Dr. Rabah, I have given her the second chance. Yes, given the second chance. So what's happening after the second chance? HPV came negative, so well and good. I will recall her in 36 months. HPV came positive, so I will see here, okay, the trick. The trick that in every HPV positive, reflex cytology should be done. Is it correct? Yes, correct. So, while the patient had 2 chances, okay, of HPV, be given her 2 chances for the CIN to resolve, CIN1. Yes. So I know, Dr. Rawa, you have said in the previous one, we will recall to the cytology, whatever the colposcopy, we refer to the colposcopy, whatever the cytology is. No, not applied here. Okay? The situation matters. It is different. When we were in the routine recall, this was the management that, remember, going to the slide, remember this slide, okay? Yes, we have this slide. Remember, we have said after 2 months is HPV positive, whatever the cytology result is, I will go to colposcopy. Yes, okay? But this when we were only following up patient with HPV positive, but not with abnormality in the colposcopy detected, not a CIN1. In CIN1, it's different, okay? What is the different, doctor? I will tell you what is the different. The different is the patient with CIN1, okay? Once she had hair colposcopy adequate, and this is confirmed the CIN1, I will give her 12 months of the follow-up, and if her HPV came negative in the 12 months, I will recall in 3 years, and if I found the HPV positive, I will do cytology as a reflex, and according to the cytology, I will go on. Here we are in this part, so you will not be lost. We are still here. What should I do here, doctor? What I should do here is HPV came positive, reflex cytology. If the cytology came negative, 3 years recall. Different? Yes, different. I will take care? Yes, you will take care. Because this is a trick and we have located. So it shouldn't be a trick anymore. HPV positive. Cytology came abnormal. This is the normal pathway. Patient with HPV positive, cytology abnormal. I'm referring here to colposcopy, and we are done with the CIN1, okay, with adequate colposcopy. And we will remember seeing, first of all, CIN1, no test of cure. Why no test of cure? Because obviously we didn't do any treatment, okay? We will recall, okay, to repeat the HPV in 12 months. The patient can be given a second chance. And in the second chance, we will see. And here, the CIN1 second chance is different little bit from the routine recall second chance. So cytology negative, recall in 12 months, and after that, recall again, and HPV came positive again. So I will C, cytology. Cytology came negative, recall in 3 years. Cytology came positive, I will go, positive means abnormal, means I will go to the colposcopy immediately. So this part clear?
Yes, ma'am.
Yes.
Yes, thank you very much. So I will go to another part. We have talked about the CIN1 inadequate colposcopy examination. Still, we have CIN2, 3, and CGIN, okay? So let me say Bismillah and we will go. CIN2 and CIN3 necessitate treatment, means that you should offer the patient a treatment because this is a high-risk lesion by the colposcope. So after you offer any patient any treatment, what should you do? Next to any treatment?
Test of cure.
Test of cure.
Yes, excellent, excellent. So it's a test of cure. It's like a reflex answer. So test of cure after 6 months is the treatment of any lesion. The question here, which is make some little bit different in the options of the exam. What is the type of test of cure? Is it by colposcopic examination or by HPV testing?
HPV testing.
Yes,
testing.
excellent. It's HPV testing. Okay, so the test of cure is by HPV testing. This is what I want to hear from you. Excellent. So came negative, test of cure, HPV test, came negative. Then we are happy. We will recall our patient in 3 years, in 36 months. So this is here our job is finished. So it is treatment, test of cure, negative, 3 years. Okay, recall. So we are happy here. Comes to the CGIN. CGIN is a little bit longer in the follow-up because it has a higher rate of recurrence. So when I compare the follow-up of CIN2 and the follow-up of CIN3, okay, it will be different from the follow-up of CGIN. So please, your job in the exam is to locate what is the lesion, comes to the situation awareness again. What is the type of lesion, okay? What is happening now? Am I now at the time of offering treatment? So next step will be test of cure. Test of cure came negative. Then for the CGIN, you will not send the patient to come back for recall in 3 years. You will repeat the screen in 12 months. And if the screen comes again negative, so it will be recall in 36 months. So here there is extra step in between the recall. This is the main difference between CIN2 and 3 follow-up plan and CGIN follow-up plan. Okay, comes again to the flashcards.
Can you please repeat that step once?
Yes, of course. We will repeat it now and you will see how easy it is. Okay, so here abnormal colposcopy. This is part from the algorithm by the guidance. I have just take a part from it to try make it easy for you to digest. So abnormal means CIN2 or 3. Okay, so we agree on that. You offered her treatment. We agree. Okay, so you agree with me that I should offer treatment for this patient?
Yes.
Yes.
Yeah, we will agree to offer treatment for this precancerous lesion. So treatment will be offered, I have to follow the treatment by test of cure in 6 months. Now, I have the test of cure in 6 months and her HPV came negative. So I will send her, bye-bye, see you in 3 years. Okay? While the other patient comes with her HPV at the time of test of cure is still positive. Here, I would say that refer to colposcopy, whatever the cytology is. Okay, so HPV positive means that reflex cytology will be done. Cytology came negative, refer to colposcopy. Because why? HPV positive. Cytology came inadequate, please refer her to colposcopy. Why? HPV came positive after treatment. Cytology came abnormal, refer to colposcopy. Okay, so how can I remember this in the exam? I want something to make it like easy for me to remember. Okay, I will tell you something. Remember, CIN2, CIN3 needs a treatment. Treatment followed by test of cure. This will be 6 in 36. Okay, means 6 test of cure and then 36 is the recall if her HPV came negative. So remember, for this slide, treatment of CIN2 or 3, then test of cure, her test of cure, HPV came negative, then say bye-bye, bye-bye, see you in 3 years. HPV came positive, what should you do if HPV came positive? Okay, please, whatever the cytology should be done, but whatever the cytology is, we will refer to colposcopy. Okay, so this is your basics of management that I can assure you that a lot of cases of the exam will come from this basic levels, okay, because they always want to make sure that you know the basics. And those
Ma'am, I
basics
want
are,
to ask this, that no
yes,
matter what the cytology, no matter what the result is, we'll always go for colposcopy. Then why do we have to do the cytology and add to the cost?
this will
Why
be this will be HPV positive in the follow-up of any patient who had a treatment. Okay, you know, HPV positive, this is a reflex cytology. They will try to do it on the same sample. Okay, cytology will not cost a lot, but it will give them an idea where are they. Okay, so we can see, yeah, thank you. So CGIN. CGIN is the big legion of today. Okay, so let's see, what is the CGIN? Before starting the CGIN follow-up plan, I've told you.
Excuse me, ma'am. One question, please. Um, as this is a new, protocol, it's a new guideline, and what we see in the recalls and in the books, the old logarithm is followed. So, in exam, if we encounter some recall or a past question, then how can we solve that? We will apply the same logarithm on that, or we will solve them with the previous logarithm.
No, dear, of course you have to follow the new updated one, because I will tell you something. First, those algorithm comes in the 2019 version, okay? And this update last one is in February and 2020, means it is early in this year, and you are required to follow the update and also the examiners. And I would like to just tell you something. All the examiners, when they write questions for the exam, they should, it's a must, okay? It's a must, it's a legal part, okay, from the question, that they should put in the reference the most updated version of this answer, okay, of the guidelines. and every question should have a reference, and every reference should be updated. What we tend to say that if you have a guideline that's updated recently before the exam, okay, so you will not be asked, means in 6 months you will not be asked in this update. But this not in the situation of COVID-19, for example, my previous lecture, because this is a global issue, okay, and you should know the update, you should know what's happening. Every day, all doctors are required in the UK to follow the new update from the NHS, okay? So you have to follow the new updates for every hot topic. Cervical screening already changed in 2019, and they have put a little bit modification in 2020, so it's required in your exam, as this you can see. Okay, I'll tell you something about the special cases, which is a good thing, that the special cases that require more frequent follow-up, like the HIV case, it's the same, still the same, not changed. Okay, means that this patient will need a more frequent follow-up in the form of annual, okay, screening. This is still not changed. And also some basics, some also problems that we will come to it, like the incomplete excision margin, it is still not changed. So don't worry, okay? You have to just make sure that the 3 algorithms of the cervical screening are well digested, and we offer some scenarios based on the new changes, and it's answered according to the new one. I will discuss some of it today with you, and I also would like to thank Dr. Rana Meher. She helped a lot also in making new scenarios, okay, of the cervical screening. Means we have the same cases, okay, but with the updated answers, okay? So don't worry, we will provide this, because really it will be helpful for everyone in September exam. January people are having more time, so they can solve more questions, be more trained. But you, as September people, you are really in situation that you need a quick flashcards for your exam, and you need to be sticking to the new answers, and you know how to approach it. So guys, I will discuss with you the CGIN. The CGIN is very important legion. They love to ask about it, okay, even in the previous recall. So we will see CGIN, okay, high risk of recurrence. Need treatment? Yes, need treatment. With treatment, I will recall the patient. I will ask the patient to come back to see her in the test of cure in 6 months. Is it correct? So still easy. Yes, easy. What will happen here that we have added a new step, another step. HBV came negative in the test of cure, so I will recall her in 12 months. This is the extra step. And HBV negative comes after the second follow-up. So I will say bye-bye, see you in 3 years. Okay, so what is the frequency of follow-up for CGIN? The frequency of follow-up is 6 in 12 in 36. Okay, so this is the meaning of the equation. We have said it, 6 in 12 in 36. Okay, so try to get it like that, 6, 12, 36. This is a normal follow-up for a treated CGIN, okay, provided that in every step her HBV came negative. So it is easy till now. So guys, what is the frequency of follow-up for a CGIN after treatment?
6, 12, and 6.
36.
Yes,
12 and 36.
in 36. Yes, thank you very much. So it's recall in 6 months, HBV came negative, recall in 12 months, HBV came negative, bye-bye, see you in 3 years. Okay, so going to the other possibility and the other hand. HBV came positive. Oh my God, so reflex cytology. Yeah, let's say that the reflex cytology came negative or inadequate. Here it's very important because it will make a difference in the plan of the follow-up. How it is? I will tell you how. We have said HBV positive. We have to do reflex cytology. After the reflex cytology done, result is either negative or inadequate. What shall you do? Here, you will refer to colposcopy. Colposcopy came negative, so recall in 12 months. Okay, so this is the thing. It's cytology negative or inadequate. Going to colposcopy. Okay, remember when I say in the follow-up of a treated lesion, we will refer to the colposcopy no matter the cytology is. Is it correct? But why, doctor, he has given me 2 boxes here? I will tell you why. This is a good question. Because according to the cytology here, the follow-up plan will be changed, will be different. How is this going? I will tell you. Here he divided the follow-up plan according to the cytology. If the cytology came negative or inadequate, in this case, you will refer to patient to the colposcopy. If colposcopy came negative or normal, you will ask for another 12 months, okay? And in 12 months, if her HBV came negative, you will say bye-bye, see you in 3 years. So this is the difference. Or if her cytology came abnormal with HBV positive while she had been treated, so this will make you worried about maybe this patient is coming into recurrence, or maybe she will have invasive lesion soon. So I will have to put an eye on her, and I will have to set a tight follow-up plan. So this tight follow-up plan is saying that if the cytology is abnormal, refer to the colposcopy. Here I would say no matter the colposcopy is, either normal or abnormal necessitate Reexcision, complete 10 years of follow-up. So again, this part. What are you saying, doctor? What I say that important rule in treated CGIN. Patient will have test of cure. At any point of her follow-up, she had HBV positive. You will do a reflex cytology. If her reflex cytology abnormal, what shall you do? You will refer to colposcopy. After colposcopy, what shall you do? After colposcopy, you have to complete 10 years of follow-up. So what is the frequency now of the equation? It changes. Yes, it changed. It become 6 in 10. Okay, 6 in 10 means that 6 in 10 years and then annually for 10 years. So here, one of the special cases that's important in your exam. I will tell you a situation and you tell me what is the plan of follow-up for this patient. So we have Miss Y, okay, that have been referred to the colposcopy because her HPV came positive with abnormal cytology, and they found it colposcopic examination, okay, and biopsy taken and confirmed the CGIN lesion, okay, which has been treated. Patient has been seen for a follow-up for test of cure after 6 months, while her HPV came positive again, and her cytology came inadequate. What's next step?
Colposcopy.
And
Refer to
Follow up
colposcopy.
yearly, 10 years.
colposcopy, and for 10 years you have to follow her up.
The patient cytology came inadequate.
Inadequate
Colposcopy
after
recall
1 year.
12 months.
Normal, recall and
Colposcopy is normal, recall in 12 months.
If
Okay,
normal colposcopy, we call in 12 months.
okay, so guys, yes, thank you very much. But when I say, because this is how it makes different in the exam, you look when I stopped and look the case in the exam where he stopped. Sometimes he will stop at this step. Requesting you, he will say that Miss X has been treated for the whole story, blah, 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 okay? And after that, the patient has been treated, so what is next? Your answer will be simply test of cure, okay? So this is one thing. While if he said that she, after 6 months, had HPV came positive and cytology has been done, which shows inadequate result. So your answer should be?
Refer to colposcopy.
Yes, excellent. It's referred to colposcopy. Okay, so here you stop. It's referred to colposcopy because we can't say what next because it's according to the colposcopy. So let's say when the patient referred to colposcopy, I will continue the story with you. When the patient referred to colposcopy, they found, okay, that there is abnormality which necessitates re-excision of the lesion. What is your plan of follow-up? Patient had re-excision.
Annually for 10 years.
Yes, excellent.
Again, test of cure for after 6 months. Do we have to do test of cure again after re-excision?
No, when we have re-excision, this is different from treatment. When we have re-excision, we have to complete 10 years of follow-up. And when it comes to you in the exam, okay, they will give you the exact choice with the same words, okay? So trust me, it is like that. The correct answer should be in the same words of the guidance. Okay, so it is complete 10 years of follow-up because the patient had abnormal colposcopy finding which necessitate re-excision. Okay, so again, cases again. I will. Yes, Dr. Sarah, because here it mentioned here in this part. You refer to the colposcopy is normal, recall in 12 months, while in this part he said, and or no re-excision. So once he mentioned re-excision, so we are here. This is what we called again, this is the situation awareness. Okay, so I will give you some example of the cases so you will be able to give me the right answer I'm searching about. I'm sorry, okay, because some disturbance in the application. Okay, so let me think with you about this answer and tell me, please. Okay. Is the screen, guys, is it clear now?
Yes, ma'am.
Yes, it's clear. Okay, so I'm reading the question for you and we will think together how to approach the answer. We have a 45-year-old woman, par 3, has cervical screening tests that reveal high-grade dyskeriosis. She is non-smoker and no relevant family history of for cervical cancer. All previous cervical screening tested normal. She undergoes uncomplicated colposcopy and large loop excision of the cervical transformation zone, the histology of which revealed complete excision margin of the CGIN. Repeat colposcopy 6 months later is normal. What shall you do here? This is your answer, guys.
Here
C.
in this case, we will repeat cervical screening in 12 months because the test of cure here after 6 months is normal, so we will recall again in 12 months.
Okay.
No, it's test of cure is not colposcopy. It should be HPV, I think.
Okay, so how can we get the answer? Which answer is the correct one? I will tell you. First of all,
E, cervical cytology in 12 months. E.
Okay, so I will just comment. Okay, I'll just comment, guys, on the answer. So follow me. First of all, we have said situation awareness first. What is the situation here? Your situation now, the patient has been treated for CGIN and what else?
CGIN 2 or 3?
Yes, she had complete excision margin of the CGIN, yes, because complete excision margin will be a little bit different from the incomplete excision margin. Okay?
Yes.
She had a repeat colposcopy 6 months later, which is normal. Okay? So when we have normal result, so next step will be according here. Okay?
Should we follow up after 1 year, then yearly, because Reexcision done and CGIN.
So there's any word here about Reexcision, guys? Can you please
No,
read
it's
the
excision. It's the first time or the primary treatment.
Yes,
not
it is the first time. Yes, it is the primary treatment. Okay, so this is the primary treatment, and this is the slide. This is the flashcard we will use. Okay, in the answer. So the patient has CGIN. She has been treated for the CGIN, and now she has been recalled in 6 months, and we have found that her result is negative. Okay. I know that in the case he have said that colposcopy done. Okay, so means that we are here. We are in this part. Is it correct? We are in the 1, 2. Can you see the arrow, guys?
No.
No.
We are here.
Yes, no.
It's normal colposcopy. What shall we do next?
Recall in 12 months.
Recall in 12 months. And when we do the recall in 12 months, what type of test we offer her?
HPV.
HPV.
Excellent. It's the HPV. Okay? HPV testing, not the cytology.
Yes, because that is positive negative before.
Yes. Cervical screening test now equal HPV test, not cytology, not cervical cytology. You will find it in the answers. You will find it in the options. Cervical cytology. Careful. Now everything changed. The cervical screening test now means HPV test. Okay, so don't choose the cytology for the follow-up. Okay, so HPV positive, so mean the answer is to repeat the cervical screening in 12 months.
Yes.
Not test of cure, because test of cure already done. Okay, guys, test of cure already done for this patient. Okay, so this patient is not for the test of cure. This patient is at this part, this particular part. What I need you to
So,
do
ma'am, for
is,
this patient,
yeah,
for this patient here, the test of cure is colposcopy. Because the colposcopic finding is only done and it's normal, then we'll consider it as a normal follow-up in test of cure.
okay.
Test of cure can never be colposcopy. It's always HPV.
Yes, it's always HPV. So what can be happening? Okay, because you deal with the situation you have as it is. Okay, I will tell you this part. Maybe the examiner didn't say, but he said that colposcopy is normal. That this patient had recall in 6 months. Her HPV came positive. Then they have done the cytology, and apparently her cytology either was negative or inadequate because they have done the colposcopy. Now the colposcopy is normal. So this should be done to the patient because we are here in this part. And because there is no other part in this diagram talking about normal colposcopy except this one. Okay, so if after normal colposcopy, it's recall in 12 months, and I'll try to make it bigger so you can see the box. What does the box say? Okay, so we are here. We are in this part, normal colposcopy. So recall in 12 months. Okay, so guys, this question specifically, okay, came before in the exams and came before in the revision programs, okay, by the official revision 1. So I'm just giving you this training of how to apply the principle of the situation awareness. Where am I? Okay, in the algorithm, back to the flashcard. And the more you have training now with the open book, means the flashcards or the slides in front of your eyes, this will be in your copied in your memory. Okay, so recalling it in the exam will be very easy, and you have to follow as it is. My role is just to explain to you the pathway. Your role is to follow it and to be expert in it. So I appreciate your role. Your role is the important part, not mine. I'm trying to make it understandable. I'm trying to make it a little bit easier, okay? But your training will make you perfect, okay? So you promise me by training on those scenarios. Let me go to another scenario for more training, and you tell me what shall we do, okay?
Okay.
So guys, for the following clinical scenario listed below, show the next single most appropriate investigation from the option list above. Each answer may be used once, more than once, or not at all. Okay, so let me see what's here. It's a 45-year-old woman. Okay, can you read it, guys? Is the screen clear?
Clear now. Thank you.
Yes. Okay, so I'm trying to make it as large as possible. Okay, so 45 years old woman, para 3, has a cervical screening test that reveals high-grade dyskaryosis. She is non-smoker, she has no relevant family history of cervical screening, or her previous cervical screening tests have been normal. She undergoes an uncomplicated colposcopy and large loop excision of the cervical transformation zone. Okay, so what is the finding? The histology of which reveals incomplete excision margin of CIN2. Repeat test in 6 months later is normal. Okay, so I will tell you, because I haven't reached this part now in the presentation. It's about incomplete excision margin of the CIN2, which is very repeated situation in the exam, and it is still the same rule, unchanged from the previous one. So if it comes in your exam, then it will be like a gift, because it is the same thing. Remember, when we have what was the previous one, if you remember, okay, if we have incomplete excision of lesion, okay, according to the type of this lesion, it's CIN2 and 3, what the follow-up plan or the management plan will depend on, who is clever and tell me? We will depend on
Test of cure, HPV.
No,
HPV.
not this one. Test of cure came normal.
Then follow up on 12 months.
HPV.
Because margin is in income.
Will you need to
Age of
repeat?
the patient.
Will you need to repeat the excision?
Age of the patient.
No, she's 45 years. No need.
It's the patient age. Okay?
No, we will not repeat. We will do this HPV test again.
Yeah, thank you very much. So I will tell you, okay, guys, this is the situation that it came before in the examination, and I like this part because it's a very famous part. Okay, and very famous repeated case, so careful guys when he tell you the word incomplete margin. So look to the lesion. What type of lesion? If the lesion was high grade CIN, not CGIN. Careful, not CGIN. I'm talking here about CIN2 or 3. Okay, so incomplete excision margin. He will tell you clearly in the exam, incomplete excision margin. Okay, so what will be the next step? Next step will depend on the patient's age. Okay, so what is the age group or the line? Is the 50 years old. So in patient under 50 or below 50, no need to repeat excision, no re-excision. It's just a follow-up. For the individuals over 50, okay, and they have incomplete excision, please repeat re-excision. Do re-excision. Repeat the excision again to clear the margin, to make sure that the whole lesion removed. So when you have in the exam incomplete excision margin of CIN2 or 3, think about the woman age. Refer to her age. If the patient is below 50, no need to repeat the excision again, just follow up. And for the patient over 50, okay, repeat the excision to obtain a clear margin. This is the trick, which is very, very important one and repeated one, and one of the cases that comes a lot in the examination. Okay, so how we go?
So ma'am, below 50, either CIN 1 or 2, we are not going to repeat, right?
No, you
Below
have
50,
you have, dear, for patient had treatment. This is the situation. Patient had treatment. The treatment means the excision. Excision margin was incomplete. Okay, incomplete excision margin. This is a special case. Come as it is. It will come like as it is in the exam.
Okay.
He will ask you about the next step.
Hello,
Will that
doctor.
require re-excision? Your answer should depend on the age. Patient below 50, no re-excision. Patient above 50, then repeat excision. Okay?
When patient age is
Yes.
patient age is 50, then what we do?
Sorry?
Not below, above. Patient is
Above
not
50,
below or
we
above
should
50, only 50. Out of
above 50, we should repeat excision.
just 50, only 50. Not above or below. Age is 50. Then what we do?
I will go with repeat excision.
Repetition. Okay, thank you.
Yes. So, guys,
Excision is done for microinvasive stage 1A1, ma'am.
cancer, this will come after. This will come after. Okay, because excision of cancer different from excision of CIN2 or 3, different from CGIN. Okay, each one of them will require a special follow-up plan. Okay, so let me go to I will read the second case, then we will go to our flashcards to finish it. 35-year-old Para 5 has a cervical screening test that reveal high-grade dyskeriosis. She is non-smoker, no relevant family history of cervical cancer. All her previous cervical screening tests have been normal. She undergoes an uncomplicated colposcopy and large loop excision of cervical transformation zone, the histology of which reveals a complete excision of CIN3. So what is next?
No follow-up.
She has been
And no
treated.
repeat excision.
Test of cure.
Has been
Cure in
treated.
6 months, ma'am.
So for
Test of cure at
every
6 months.
treated
Test of cure after 6 months.
Should we do test of cure after 6 months? If negative,
Yes.
recall in 36 months. If positive,
Yes.
colposcopy.
Yes, excellent. Okay, so it's repeat cervical screening in 6 months. This should be your answer. We should repeat. This is a test of cure. And this is also one of the easiest and common situation comes in the exam. You want just to check your basics, that you know that after every treatment you should follow by a test of cure. Okay, so we clear the basics and we will clear the exam. Yes, dear, it's test of cure in 6 months. So last case.
Dr. Rabah.
Yes, Dr. Mustafa, how are you?
Fine, thank you. Thanks for this nice presentation. My dear colleague said HPV, if negative, if positive, refer to colposcopy. I just want to remind him, if positive, reflex cytology, not colposcopy.
Okay, thank you very much, Dr. Mustafa. So you noted this. Thank you very much. Very alert, mashallah. Thank you very much. So guys, let me say that 49-year-old woman Para 1 cervical screening test revealed borderline changes, and HPV test is classified as high risk, means that she is positive. She is non-smoker, had no relevant family history for cervical cancer. All previous cervical screening tests have been normal. On examination, she looks well, BMI 28, abdominal palpation normal, vaginal examination is normal, and cervix looks normal. So what will you do?
Refer to colposcopy.
Reflex cytology.
In 6 weeks.
And if cytology is positive, refer to colposcopy. If cytology is negative, you recall after 12 months.
Refer to colposcopy in 6 weeks.
Okay, patients have borderline changes and HPV came positive. Okay, so what will be the next step? You remember where we are now? the situation awareness of this case?
Ma'am, kindly show where we are on the flashcard.
Yes, of course. Yes, HBV came positive. Borderline changes. Okay, so what will be the action?
Colposcopy.
Yes, colposcopy.
Yes, colposcopy.
Okay?
Colposcopy, yes.
Yes, it's colposcopy. Thank you very much. So let me try to continue the flashcards. It will need from your side more training. So what I'm going to do is I will post more scenarios on Dr. Mustafa's group, okay? And I will ask you, please, guys, to search in the flashcards which one applied to the situation and just found the answer. It will be like a memory game, which will be very nice and helpful for your examination. Okay, so
Thank you so nice of you.
you're welcome. So guys, we have talked about the incomplete excision margin of the CIN and CIN2 and CIN3. Is it correct?
Yeah.
Okay, so what will happen if the patient has CGIN with incomplete margin? CGIN, this one with the high risk. You will offer her a re-excision, is it correct?
Yes.
Yes, but what happened in the special cases? What happened in the special cases is the patient deny re-excision. So you will have one of the scenarios, possible scenarios of your exam. Patient had incomplete excision margin of the CGIN and she denied re-excision. Remember, the one who have done the re-excision, we have said we will follow up for 10 years. Okay, so now deny re-excision.
We will call her 6 months after to repeat HPV.
Okay, so if the patient had incomplete excision margin, like for example, he tell you that in the histopathology sample, they have found that the margin is not complete or incomplete excision margin of the CGIN. The situation is the patient is not willing to do any procedures, okay? She would prefer conservative management. So what should you do? First, you should offer her colposcopy, okay? And MDT, because this is a risky case and they need an MDT to decide if this patient is a candidate for a conservative management and long-term follow-up, or this patient may need reassessment again of her lesion. Maybe this lesion is not correct from the start, or maybe we need to do any further management for her or more further investigation to exclude any cancers. So this will not be your decision at all, but you will remember that your follow-up plan for this patient started by colposcopy, okay, and MDT. And after the colposcopy, okay, patient will be offered a test at 6 months. And if the test negative, she will be having another test at 6 months. And if the second test is negative, she will have 9 years of annual follow-up. Okay, so 9 years of annual follow-up. This is what you should put a plan for this case. Don't forget the MDT. It's 6 by 6 in 9 years. Okay, so 6 months HPV test, 6 months HPV test. Okay, and followed by 9 years of annual follow-up. Remember which case it is? It's the incomplete excision of CGIN and patient deny re-excision. Okay? The incomplete excision situations are important in your exam. Okay? So remember, CGIN incomplete excision management plan will depend on the age of the patient. Below 50 or above 50. Remember, this is for the CIN 2 and 3. Again, patient had primary lesion, CGIN, incomplete excision of CGIN, patient deny re-excision. Please remember the MDT. Patient will need the MDT review. For every time she comes for the follow-up, she will need every time to be reviewed. So always MDT. Patient will have a colposcopy, then she will have HPV test at 6 months. Then if it's negative, she will have test in 6 months, again, repeated test, and finally, she will be on a follow-up plan, a long-term follow-up plans for 9 years annual follow-up.
And ma'am, for the patients who have complete excision, their follow-up for 10 years is annual follow-up. It's not 669, it's annual follow-up for 10 years, right? The ones that agree for the re-excision.
Yes, it should complete. She should complete 10 years of follow-up. Okay? And when it comes in the exam, when it comes to the exam, don't worry about the calculation. It will come as it is. That the patient should complete 10 years of annual follow-up.
In this case in which she's denying re-excision, when you're doing the colposcopy, are you doing the HPV at the same time, or you call them after 6 months of colposcopy for HPV?
You have one basic HPV, okay? After colposcopy, 6 months HPV, then another HPV test. So you have 2 HPV testing. After 6, the first one after 6 months, second one after 6 months. Then if it is all negative, go for the 9 years of annual follow-up.
Okay, thank you.
Okay.
Ma'am, one last question. I want to ask that in, for example, when the situation comes as mild, moderate, severe dyskaryosis, does that apply for CIN 1, 2, and 3 respectively? Mild, moderate, severe.
Mild dyskaryosis or severe dyskaryosis. This is a finding of
cytology.
Yes, it's a finding of cytology. Once the patient had treatment, means the patient or classified as CIN 1, 2, 3, so means that the patient had a colposcopy already.
So CIN 1, 2, and 3 or CGIN are colposcopic findings, and mild, moderate, severe are colposcopy. Cytology, right?
Yes.
Yes, cytology. And madam, borderline changes? Borderline changes include what?
Cytology, usually cytology.
Right, mild and moderate come into borderline.
Mild and moderate comes to in borderline. No, it's not like that. Borderline means that it's a borderline that they can't say.
Okay, get it.
So guys, remember, go back to the colposcopy, please. Okay, remember the 2 arms of the colposcopy because I have to finish this algorithm. This algorithm is one of the new algorithms. This is the second one, and we have to clear it. Okay, we have cleared this one first. Okay, this is for the cervical screening protocol, the general one. And we are going now to this one to make sure we have clear it and understand it, okay? And then we will go to the third one and we will be like have all the basics of the cervical screening, which can be our building unit for the problem solving. So colposcopic examination, as I told you, either it's adequate colposcopic examination or inadequate colposcopic examination. I will start now by revising the adequate colposcopic examination. It was either you found no CIN or on biopsy, or you found no colposcopic impression of CIN. It is the same. So colposcopy found no CIN. So what you should do, you will see, okay, the HPV result, the index 1. If it was positive and cytology is less than low-grade lesion, so recall in 36 months. While if HPV positive and cytology is equal to or more to high grade or borderline endocervical, so your answer should be discussion at MDT within 2 months. What is the story of finding of endocervical borderline changes? The thing is, once you have borderline endocervical, okay, so you will need to make sure about the presence or the nature of those cells, where these cells comes from, okay? So what shall you do? Can anybody of you tell me what shall you do if you have the endocervical cells?
Endometrial biopsy?
It depends on age, and if less than 40 years, no need to do anything. But if more than 40 years, then if it is she's coming within menstrual cycle, 12 days of menstrual cycle, no problem. But if after 12 days of menstrual cycle, need to do endometrial biopsy.
Okay, thank you very much, Dia. Okay, so I will tell you what is the new guideline or the new, as you can see, okay, the new guidance or the algorithm says, when you have endocervical changes, the patient will need urgent referral, okay, urgent referral to the colposcopy, okay. Patient must be seen at colposcopy within 2 weeks, which is mean urgent referral, because we know that the urgent referral should be seen within 2 weeks. Is it correct? And patient will be referred to the MDT. Okay, guys, this is what the new algorithm say. Okay,
yes.
Remember, this part of the MDT and urgent referral to colposcopy will be your question in the exam. So what you need to do is you need to follow the new algorithm. What does the new algorithm say? The new algorithm say you will need urgent referral, patient must be seen in colposcopy within 2 weeks, and MDT review. This MDT review will take how long? Should be done within 2 months. MDT referral or MDT meeting for this patient. Patient should be discussed in the MDT meeting within 2 months. Okay? So guys, this is one of the flashcards that can make a good case in the exam. Let me see what will happen in inadequate colposcopy examination, and how you will know in the exam that this is inadequate. Either he will tell you clearly that this is inadequate examination, or the colposcopic examination was inadequate, or he will tell you that there was difficulty during the colposcopic examination, or difficulty to visualize the cervix, or difficulty to make sure about the extent of the lesion. Okay, so the colposcopy examination will be considered inadequate when there is a difficulty. Okay, so what shall you do in inadequate colposcopy? One also of the new cases that you need to be aware of. Inadequate colposcopy means you will see if the case HPV positive, okay, and cytology is normal or below low grade, so repeat colposcopy in 12 months. This case had a repeat colposcopy. Can you remember any case that we have discussed today with repeat colposcopy? It's not yet, okay? It's the case with repeat colposcopy in 12 months. This is the case with inadequate colposcopic examination, okay? And if again after 12 months is inadequate, please consider leads, okay? So consider treatment. Inadequate examination by the colposcopy, while the HPV was positive and cytology is high-grade lesion or borderline endocervical, advise leads. Okay, so advise treatment. So here, guys, he didn't tell you any CIN. He didn't tell you anything. He just said colposcopy examination was inadequate. So you ask yourself, what can I do now? Okay, refer to the case. See her HPV. HPV was positive and cytology is high grade. Please choose leads. Offer the patient treatment. Local excision. If the colposcopy is inadequate, while her HPV was positive, but the cytology is low grade or normal, remember, you can repeat the colposcopy in 12 months. Guys, this algorithm will need so many times of studying and repetition. You can do even your own flashcards, okay? But this must be with the help of cases. So you can reach the pathway, you can apply it to the cases, okay? So I will repeat it again to make sure the story, I will repeat the story from the start to make sure that everybody of you got it ready. So when you see the three algorithm of the cervical screening, you will be feeling any trouble in understanding or translating this into a clinical scenarios. So let me see, HPV test came positive. Can anybody of you tell me what will happen?
Cytology. Cytology.
And according to the cytology came abnormal. What you will do?
Colposcopy.
Colposcopy.
Yes, excellent. Cytology came negative. What you will do?
Recall
Repeat
after
after
12
12 months.
12 months.
Okay, now I repeated the HPV testing. It came negative.
routine recall.
Normal follow-up.
First, the patient was having HBV positive. Her cytology came negative. I offered her rescreen in 12 months. Okay? HBV came after the 12 months. So, routine recall. Okay? Thank you very much. Again, the rescreening came positive. So you can write down in the chat box. So her HBV came positive. I will follow with you with the spotlight. Her HBV came positive. We are here. So her cytology should be done. Is it correct? After HBV result every time comes positive, I will do a reflex cytology. Here cytology came negative again. What shall you do?
Rescreen after 12 months.
Yes, excellent. So I will rescreen in 12 months. And if you want to remember what we said, I will give the patient a second chance. Okay? So I will say after the second chance, we repeated her HBV and we found that HBV came positive. So reflex cytology should be done. Okay, and no matter the cytology is, you will request colposcopy referral. Is it correct?
Yes, ma'am.
Yes, excellent. So this is the pathway. First pathway. This is a clear one and an easy one, and most likely to come in your exam as well. Let's go to the next one, the colposcopy examination, and how can you solve it in the exam. In the colposcopy examination, you will look to the word. Is it adequate colposcopy or inadequate colposcopy? Adequate colposcopy means that he will give you a result, means that he will tell you this is a CIN1 or impression, colposcopic impression of CIN1 or CIN2 or anything. Okay? So this was adequate colposcopy and there is a result for this colposcopy, and according to the result you will move forward. So let's say our patient that have been referred to the colposcopy above in the previous slide came now to the colposcopy clinic. We have done the colposcopy examination. The colposcopy examination was adequate and it showed no CIN or no impression of the CIN, no colposcopic impression of CIN, means that it's free. Okay, so what is your action? Your action in the exam is to go and look for her HBV result from the start and her cytology result. And according to this, you will decide what is the action. Index HBV means her HBV in the case, okay, was positive and her cytology was low grade cytology or normal cytology. So you will ask the patient to be seen in 36 months, okay, which is a good thing for everyone. So let's say the patient colposcopy came normal, no impression of CIN, or biopsy has been taken and confirmed that it's no CIN. So colposcopy normal, but her HBV was positive and her cytology was high grade. So does this make anything for you? No, it doesn't mean anything. So this patient will need an MDT review. This patient will need an MDT review. She will need a discussion with the MDT in 2 months. Why? Because her result, just try to remind yourself like that. Her result doesn't make sense. Her cytology was high-grade lesion, okay? Or she had a borderline endocervical cells with HPV positive. Colposcopy say nothing. Colposcopy adequate examination say we can see nothing. So this patient will need an MDT review. This patient need to be discussed at the MDT meeting within 2 months. Important box for the exam because it's new one. So go for the other arm. Patient had adequate colposcopic examination, okay? While here adequate colposcopy examination, sorry, because apparently we have lost the screen. While here adequate colposcopic examination showed that I'm trying just to make it abnormal biopsy or CIN plus or colposcopic impression of CIN. So this will be managed according to the abnormal colposcopy finding we have discussed. What is the abnormal colposcopy finding we have discussed? We have discussed if we have CIN1, what shall we do? If we have CIN2 or 3, what shall we do? We have discussed CGIN, what shall we do? Here at the slide, corresponding slide. So CIN1 on the colposcopy found. So please recall in 12 months, no need to offer any unnecessary treatment. And after the 12 months, if it is found HB negative, please recall in 36 months. And if found to be HB positive, please do cytology and according to the cytology, go as before, okay? CIN2 or CIN3 offer treatment, offer test of cure after treatment, 6 months, and if after 6 months HPV came negative, recall in 36 months. If HPV came positive, you will do a reflex cytology, but no matter the cytology is, you will offer colposcopy. CGIN means offer treatment to this patient, means high risk of recurrence, means you will need to make extra step in the follow-up, means that you will offer treatment, test of cure, then at 6 months, if the HPV came negative, do a rescreen in 12 months, and if came negative, do a recall in 36 months or 3 years, means the frequency of recall of treated CGIN should be, if everything is normal, means 6 in 12 in 36. The frequency of recall for CIN1 and nothing is to recall in 12 months, and in 12 months 36. So it's 12 in 36. No treatment. CIN2 and 3 treatment plus test of cure. Frequency of recall is, if everything is normal, 6 in 36. So I'll just need you to write it down as a note, okay? How to do the frequency of follow-up for every abnormality on the colposcope. CIN1, CIN2, CIN3, and CGIN. Again, CIN1, 12 in 36. CIN2 and 3 is 6 in 36. CGIN is 6 in 12 in 36. Okay, so I have added a new step. Comes to the part of incomplete excision margin. Okay, incomplete excision margin means that either you have the lesion CIN2 or 3, so the plan of follow-up will depend on the patient age, below 50 or over 50. Okay, so below 50, you will not need to repeat the excision and the follow-up as normal. Okay, while if the patient had incomplete excision margin of CIN 2 or 3 and her age is 50 or more, 50 or more mean repeat excision, okay, to obtain a clear margin. Very important case in the exam. The next case is very important also as well. It's the incomplete, sorry, it's the incomplete excision of CGIN and patient deny re-excision. If the patient had incomplete excision of CGIN and she has denied the re-excision, okay, remember this patient will need colposcopy, she will need MDT, okay, and her frequency should be HPV at 6 months. If negative, it will be HPV, repeat the HPV at 6 months, and if negative, 9 years of annual follow-up. Again, okay, this is the important cases that usually appeared in the recall, so it can be a candidate for the new exam. HPV and endocervical changes. If you have endocervical changes, okay, so you will need urgent referral. Patient must be seen at the colposcopy within 2 weeks and referral to the MDT. And this MDT discussion should be done in 2 months. Coming to colposcopic examination, while the colposcopic finding or examination was inadequate, part of the new algorithm. Inadequate, okay, means that you will go to the HPV result and see the original in the case. Patient had HPV test positive while her cytology was normal or low grade. So repeat colposcopy in 12 months. Repeat colposcopy in 12 months. If at the time of repeat colposcopy, the result is again inadequate colposcopy, please consider treatment, and this treatment will be by LIDS. Okay? Coming to inadequate colposcopy examination was refer to the HPV if it is positive and cytology is high grade or borderline endocervical changes. Take the safe side and offer the patient LIDS, offer the patient treatment, because her original HPV positive and her original cytology is high grade lesion. Okay, so here we will be done with the second algorithm of the 3 new algorithm comes in the guidance of the cervical screening. Here is my little bit trial as a flashcards to you, where you have colposcopy with an adequate sample If the result is inadequate and the original HPV is positive, low-grade lesion or normal, repeat colposcopy after 12 months. While if the result is inadequate and HPV is positive with high-grade cytology, okay, or HPV positive with borderline endocervical changes, or offer leads, okay? Offer the leads means offer the treatment because you have high-grade cytology with HPV means most probably this case is having a problem, okay? This, remember again, this is applies to what situation? This apply to the situation of colposcopy with inadequate sample, okay? This apply to the situation of colposcopy with inadequate sample. Going to last part, okay? I have discussed it, but I need to repeat it with you. CIN1 on biopsy, or he said colposcopic impression of CIN1. Again, recall in 12 months, and we have discussed this. If HPV came negative, bye-bye, see you in 3 years. If HPV came positive, we will do cytology. According to the cytology is the follow-up plan. Cytology abnormal, refer to colposcopy. Cytology negative, again, give her a second chance and recall in 12 months. And after the 12 months, it means after total 24 months, after the second chance, if her HPV is persistently positive, do cytology. If the cytology negative, bye-bye, see you in 3 months. If the cytology is abnormal, refer to colposcopy. Okay, this is for the CIN1. CIN2, again, I just want you to remember the basics. Abnormal means CIN2 or 3, offer treatment, test of cure at 6 months. HPV came negative, bye-bye, see you in 3 years. HPV came positive, cytology should be done, and referral to colposcopy, no matter the cytology is. Remember, 6 months of test of cure, HPV positive, equal colposcopy, no matter the cytology result is. For the CGIN lesion, okay, you need to remember this is a high risk of recurrence lesion. This lesion will necessitate treatment, recall in 6 months, and if negative, recall in 12 months. If negative again, recall in 36 months. So the frequency of recall to this patient is 6 in 12 in 36. Okay. Incomplete excision and patient of CGIN and patient deny re-excision, please remember this case need to be discussed at the colposcopy MDT, and she will be offered 6 months HPV testing. If negative, repeated at 6 months, and if negative, annual follow-up for 9 years. This part, hopefully, okay, by this part I have done my job of today, okay, and the second part of this lecture will be arranged with Dr. Mustafa and the colleagues. I'm so sorry because I have a really busy schedule and really busy revision with September people. I know you are all also my candidate, my beloved candidate, and I need really to help you. So today will be the day you discuss the basics of the colposcopy and cervical screening according to the update. You will remember my flashcards. I will post some cases which is originally helped by Dr. Rana, okay, and we will see how your approach to the cases and how you apply the basics of the cervical screening and how you apply the principles of situation awareness and going to the flashcard and then pick the answer and finish your mission telling the examiner, yes, sir, I have read the guideline. Thank you very much, and I need you to pray for me, okay? I will pray for you also and see you, inshallah, next session. Thank you.
Thank you so much, ma'am.